We're very honored to have Dr. Darren Roberts with us today to give the lecture. Dr. Roberts is a physician with a subspecialty in nephrology, clinical pharmacology, and addiction medicine. He completed his medical education at the University of Queensland and received his PhD from Australian National University. He completed part of his fellowship training in nephrology at Cambridge University. Dr. Roberts is a staff specialist at the Royal Prince Alfred and Concord Hospital and conjoint associate professor at the University of New South Wales. His research interests are in the broad field of pharmacotherapy and nephrology. We hope that you enjoy today's lecture.
Hello, everyone, and thanks very much for the opportunity to come and talk to you about this topic, which I really find is a very fascinating topic. My name's Darren Roberts. I'm coming to you from Australia in Sydney. My background is I've got training as a pharmacist and a physician, and my main area of work is that of nephrology and clinical pharmacology and toxicology. I work at a number of institutions here in Australia. And so I'm going to be talking to you today about changes in pharmacokinetics in patients with kidney disease. By way of overview, these are the topics that we'll be covering today for the first part of this session. So first of all, what is the problem? Well, we know that chronic kidney disease and acute kidney injury are relatively common conditions, particularly for those of you who work in acute care settings such as a hospital. And we also know that drugs are regularly prescribed to patients with impaired kidney function. What we're learning more and more about is the extent to which kidney function impacts on the disposition of many drugs in the body. And so when we are prescribing or dispensing or reviewing medication orders for patients who have kidney disease and are being treated with medicines, we need to be aware of how these differ between patients with normal kidney function. We know that patients with impaired kidney function are a vulnerable population, particularly if they've already been admitted to hospital with an acute illness. And the actual changes that we provide or would institute for the management of these patients really depends on a number of factors, including the patient themselves and the drug we're prescribing. And so thinking about the prescribing of medicines to patients with impaired kidney function provides the opportunity for us to provide patient-centered care. So why dose adjust? Well, we dose adjust for the purpose of reducing adverse drug events. There are two sorts of adverse drug events: adverse drug reactions, which can relate to an excessive exposure, but also we can get treatment failure if we have subtherapeutic doses. Now, so we may have a subtherapeutic dose because we are so concerned about the risk of accumulation of a drug that we reduce the dose too much. So then we need to understand that when we're prescribing a few features. First of all, we need to know what the renal function is at the time that we're prescribing. And if there's any changes to the kidney function, if this is an acute change or a chronic change compared to, for example, a reference population. And when we're doing this, it's largely based on blood results, notably the serum creatinine concentration. But in some cases, it's also useful to understand the etiology of the impaired kidney function, because this may give insights in terms of changes in pharmacokinetics, but also whether or not there's going to be progression and changes. And when we're thinking about pharmacokinetics, we're thinking about clearance, because this is the primary factor that relates to the maintenance dose. So the challenge that we have when we are supervising the management of patients with kidney disease who are being prescribed drugs is that there is, in many cases, and it's quite unfortunate, limited data about the pharmacokinetics of many drugs in patients with kidney disease. In some cases, the data is even absent. And this is particularly the case for new drugs. So we need a position to come from when we are prescribing these drugs. So we need to think about having a rational approach to the prescribing in every patient with kidney disease. And this involves us having some attention to the methods for assessing kidney function, but also knowledge about pharmacokinetic principles. So let's have a brief revision about some principles about the kidneys. So the kidneys are a key organ for the elimination of drugs. It does this through a number of mechanisms. The first is filtration. This is one we'd know the most. Filtration is a passive process for which the physiology is well defined. And we quantify the filtration process through GFR, or the glomerular filtration rate. And in practice, this is largely based on the measurement of serum creatinines, which are then applied to various formulae. But there is also active secretion, and this is happening to a larger extent than we had previously fully understood. Secretion is an active process whereby there's various transporters, particularly on the proximal tubule, but also in the distal tubule. And this can have a variable contribution to the overall clearance, and it largely depends on the particular drug and the transporter. There are some drugs, for example, metformin, that are almost completely eliminated by the kidney, but their clearance is about 4 times higher than that of GFR, because the transport through these active transporters in the proximal tubule is so active and so efficient that the amount of drug which is removed from the kidney far exceeds that you'd see from the GFR. And the kidneys also have a role for metabolism, where they biotransform some drugs, for example, imipenem, and Vicodin. And the extent to which chronic kidney disease and particularly acute kidney injury impact on this biotransformation is really very poorly defined. So just a quick overview of pharmacokinetics and the way I think about pharmacokinetics when I'm thinking about the management of patients with kidney disease. So as we'd be aware, pharmacokinetics describes the effect of the drug on a body. And it reflects multiple physiological processes, including absorption, distribution, metabolism, and excretion. And ADME is a very useful way to remember those. Each of these processes can be altered in patients with kidney disease, and they can therefore impact on therapeutic outcomes, so they should be considered. And the concentration time profile of a drug reflects the net effects of these pharmacokinetic processes following drug administration. This is a concentration time profile, as you'd be aware. So when a drug is taken orally, there's a short gap until it gets into the bloodstream, where the concentration then increases. And this is the absorption phase, and the Cmax is the highest concentration that's seen. This occurs at a time known as a Tmax, and then it decreases over time, and the rate of elimination is defined by the elimination half-life, which is the time it takes for the drug concentration to decrease by half. These are important principles because we're going to be referring to them multiple times during this talk, but I'm sure they're principles that you're all very well familiar with. There's a number of pharmacokinetic properties that we're interested in. The first one are what we call the primary pharmacokinetics, and that relates to the volume of distribution and the clearance. Volume of distribution is important because it determines the Cmax. Clearance is very important because it determines a maintenance dose. Clearance is a key factor that is impacted on by kidney disease, but there can also be some changes to volume distribution, and we'll talk about this in more detail. These two factors are used to determine the half-life, and we'll talk more about that in a moment. And there are some other equations which I use not uncommonly as part of my clinical practice, and I'm sure you do too, where we can use these different pharmacokinetic principles to look at things such as the dosing rate and also the area under the curve for interpreting pharmacokinetic data. So let's just remember about clearance. So clearance determines a maintenance dose. I'm going to say that a few times during this talk, and I'm sorry to repeat myself, but it is such an important principle. The total clearance is made up of the clearance of multiple different pathways that exist in the body. So it's the clearance of the kidney and the clearance of the liver and other clearance. So in the context of kidney disease, that may relate to, for example, dialysis. We won't be talking about dialysis today because I understand that's been covered by another presentation. So when we're thinking about the total clearance of a drug, we need to think about all these various parts. As we can imagine, in patients with chronic kidney disease, we'd usually assume that this is the only component that would change the kidney and the others would remain the same. We're going to be talking more about that later. Clearance relates to half-life as such. If the clearance goes down, then the half-life will go up, so it will persist for longer in the body. But I'm sure you're all aware of that. These are 3 patterns whereby drug clearance varies with GFR. Now, this is a diagram which really incorporates pictorially the equation that I just shown you. This shows how as GFR decreases from normal down to 0, there are changes in drug clearance. So if we start with drug B, for example, the red line, we can see that they're directly proportional. When you've got no kidney function, you have no drug clearance. And this would be described as a drug whereby all of the clearance is due to the kidneys. And examples of that might be, for example, with antibiotics, the beta-lactam, or for anticoagulants, it could be dabigatran. Drug C is a drug whereby no matter how GFR changes, there is no change in drug clearance. So this would be a drug which has no kidney clearance and or very minimal kidney clearance, and all the clearance is via, for example, the liver. So again, if we go back to our examples of our antibiotics, this may be a macrolide antibiotic, or for anticoagulants, it might be, for example, warfarin. And drug A is where there's a combination. So there is some decrease in drug clearance as GFR decreases, but not all the way. There are some other processes, for example, the liver. And again, if we go back to our examples that we had before of drug classes, antibiotics, an example may be a fluoroquinolone, such as ciprofloxacin, and for an anticoagulant, it might be, for example, rivaroxaban. So we can see here from this picture that how we dose adjust various drugs will depend in part on which of these patterns they most likely relate to and the extent to which we change. Drug B is quite easy. With a halving of the GFR or kidney function, we get a halving of clearance, and therefore we halve the dosing regimen. So just to revise about principles of dose adjustment. There's a few principles to consider. And I'm sure these have already been covered elsewhere. We need to consider our therapeutic target. We need to consider if we need to give an initial dose or a loading dose. What is our maintenance dose and dose frequency? When we should adjust the dosage. And where possible, if we should be performing some sort of therapeutic drug monitoring. To be able to consider all of these factors requires a prescriber or other healthcare professional to obtain published pharmacokinetic data from a comparable patient population. And in the case of patients with impaired kidney function, this is often lacking. Further, and we know this from any area of pharmacology and pharmacokinetics, we know there's always marked interpatient pharmacokinetic variability. And so that can always add some degree of uncertainty to some of our predictions. But we'll try and address some examples of this in the presentation today. So the maintenance dose and the dosing frequency largely depends on clearance. I mentioned this to you before. Drug clearance varies widely in patients with impaired kidney function, depending on what their kidney function is. The decrease in drug clearance with impaired kidney function prompts either a decrease in the maintenance dose, meaning we give a smaller number of milligrams, or an increase in the dosing interval, meaning that we extend the frequency of the dosing. Either of these decisions can be made in patients with impaired kidney function, but the specific one we do may depend on the drug in question. We'll talk about that with an example later. It may also depend on the toxicity profile of the drug, whereby giving bigger doses less frequently may predispose to some toxicity. This is, of course, is offset by the fact that less frequent dosing can aid compliance with our patients. So when we have a change in the pharmacokinetics in patients, it can have different impacts on the concentration time profile. If the black line is showing what happens with normal pharmacokinetics, if there is a halving of clearance in a drug that's taken orally, we can see what happens with the red line. There's a slightly higher concentration, and then it persists for longer. If we contrast that to patients who have a doubling of their volume of distribution, we get what we see in the blue line, whereby the concentration, the Cmax, won't be as high because there's a relative dilution. It's got more volume to distribute across. And again, the half-life of elimination is long. So these are the differences exerted by those two changes in pharmacokinetics. And so then thinking about how that may impact on therapeutics, we see this. With the red line, which is a halving of clearance, we can see that there is accumulation, and it occurs rapidly. The concentrations go up. This happens if we do not change the dosing regimen in the context of impaired clearance. And this is a very important consideration that we must always think about in patients with impaired kidney function. In contrast to volume of distribution, a doubling of the volume of distribution, we get a lower concentration, but again, we get accumulation. So we still do get accumulation to the point that it can cause toxicity, but it just takes longer to occur than we see with the halving of clearance. As we'll outline later, you can also get an increase in volume distribution, as well as a decrease in clearance in patients with impaired kidney function. So both of these factors may be occurring. But what it does tell us is that we need to be very careful about dose adjustments for our patients because it's very important. Let's consider the prescribing of gentamicin to a patient with advanced kidney disease. I like to use this example because it always gets the attention of pharmacists in particular, but all of us who work in healthcare. It's a bit of a prompt. Why would someone prescribe gentamicin to someone with end-stage kidney disease? Actually, there are some tricks around how we can do that, but we won't be talking about that today. We can see here that prescribing gentamicin, we get if we don't make any dose adjustments, then the red line shows we're getting accumulation. So we can address that by doing two things. Given that we know that the efficacy of gentamicin is related to how high the concentration is, we know that we shouldn't be decreasing the dose. What we should instead do is increase the frequency of dosing. And when we do this, for example, to second daily, we can see that there's less accumulation, but still there is accumulation. If we go to third daily dosing, then we can see again that there's less accumulation. So just simply by prolonging the dosing interval helps to decrease toxicity. Well, we think we do still have a very high area under the curve, which may predispose to toxicity. And the other issue that we have from gentamicin in this example is that within this time frame, we've now only given 2 doses, whereas previously there'd been 6 doses. So we've actually possibly compromised some of the benefits of giving gentamicin in that case. So although we were able to make some adjustments to the dosing regimen, we may still be compromising patient outcomes and increasing the risk of adverse drug events. So let's talk about some more general considerations in patients with kidney disease. So kidney disease, as I've already introduced to you, has multiple effects on the pharmacokinetics depending on the drug and the clinical context. The 2 groups are very different. Chronic kidney disease is a slowly progressive disease, sometimes over months, but more often over years. So what we're seeing physiologically is generally fairly stable. The kidney function does not change over months, neither does a volume of distribution. In contrast, acute kidney injury is a rapidly evolving state, and therefore there's rapid changes in volume distribution and clearance. And so each scenario requires a different approach to drug dosing, and we're going to address each of these individually. Patients with kidney disease are prone to changes in both of these, and they're also prone to coming into a hospital with acute and chronic conditions. And as I've already demonstrated with those figures, if there is drug accumulation, then that may actually occur over weeks. And so therefore the onset of drug toxicity is insidious. So we need to anticipate the potential for this to occur and to prevent it from happening. But we also need to monitor our patients closely to identify if it occurs. Our job when we're prescribing or having some other oversight of drug therapy is complicated largely due to the lack of data in kidney disease. Dose recommendations are frequently based on limited data, or they're just not made. And there may not be an opportunity within, for example, recommendations to fully account or understand about inter-individual variability. It's older data now, but things haven't changed much. A study was produced which showed that between 2002 and 2007, only about 57% of new drug applications to the FDA even examined pharmacokinetics in kidney impairment. And only 44% of those had data in patients with such severe kidney impairment that they were on dialysis. And this reflects an FDA policy that manufacturers are not required to determine the impact of kidney disease on drug dosing. So this is a bit unfair for our patients because they should also have access to new therapeutics for whatever the condition that's being treated is. And it's also a challenge for us to provide guidance in terms of what dose to prescribe. This is a paper which really fascinated me when I first read it back in 2006. It was published by a US colleague, Tom Nolan, who's a PharmD. And what he showed here is he looked at the erythromycin breath test. So this is where erythromycin is injected and then it's metabolized. And one of the metabolites is 14 carbon labeled and CO2. And so then it's breathed off. And so it's a method by which we can look at the pharmacokinetics of a drug. What they did here was they looked at the pharmacokinetics of erythromycin immediately before dialysis. And then in another patient, they did it immediately after dialysis. And you can see, sorry, in the same patient. So you can see here that the active performing dialysis caused a change in pharmacokinetics. Now, this is a drug that's largely metabolized, and therefore this increase in the metabolites suggests that the active dialysis increased the activity of the liver enzymes. And that's odd, and that's confusing, and that's really interesting, because what that shows us is that in patients with end-stage kidney disease, there is circulating, the theory behind how this works is that there's circulating uremic toxins, and these inhibit the cytochrome P450, or perhaps they also inhibit transporters. And this causes changes in non-renal clearance of drugs. And that also these effects are fairly rapidly reversible, because simply doing dialysis was able to reverse them, or at least minimize them. So what this says to me is that patients with chronic kidney disease, and particularly patients with acute kidney injury, can be predisposed to changes in non-renal clearance as well. And therefore it's something that we need to understand. Unfortunately, there's not enough data to provide clear guidance on this. So instead it becomes a research priority for the future. We'll talk more about that as we go through.